Mm. And then when it comes to, so you've mentioned a couple of things that hint at the social determinants of health, for instance. Are there any factors that you think may be driving these rates? I'm thinking a little bit about, maybe some gaps between primary care and, let's say, endocrinology or neurology and things
Mhm.
like that, or even things that have nothing to do with the hospital system.
Mhm.
What do you think is causing this kind of persistent
Mhm.
rate?
So that's a really good question. One of the things that I like to do is applying the socio-ecological framework when I think about this. So first you're looking at it on the patient level, then you're looking at it on the provider level, then you're looking at it more on the institutional level, and then policy level. So on the patient level, when we actually did some interviews with patients, a lot of it was just not knowing. Like people don't know to check their feet every day. They don't know what to look for. They don't know what proper footwear is. And for a lot of our patients, a lot of them are immigrants or second generation from the Caribbean. They're used to walking around barefoot or in flip flops or chancletas and not understanding and realize that when you're walking in these streets in New York, they're dirty, they're rocks, there's glass. And when you have diabetes, very often you have nerve damage. So you may not feel if something like that gets in your shoe, whether it's a sneaker or a flip flop. And so what happens is someone's walking, they're not realizing that there's this ulcer forming because of one of these things. Someone could step on a nail and it's going through their toe, but because they have this nerve damage, they're not feeling it. So very often that's what's going on with the patient. On the provider level, sometimes, unfortunately, we're dealing with implicit bias. And that means that sometimes our biases prevent us from giving the patient the best of care. So, for example, an older patient, someone may assume, oh, you're not going to be able to use diabetes technology. So I'm not going to offer you something like a continuous glucose monitor or a pump to help you control your sugars better. And that could then lead to that patient not getting the best glycemic control because we're assuming that are not capable of doing it. The other issue that can come into play for us as providers is insurance companies. So I can write a prescription for what would be a great medication, but then I have to do a prior authorization, which could be a lot of back and forth in time.
Mm.
And at the end of the day, if the insurance company says no, my hands are tied and I may have to then give substandard care to a patient. So those are some of the things on the provider level. And then we think about the institution. What's the access to care for our patients? So the Bronx, we have public transportation, but if you live on the west side of the Bronx, getting to the east side of the Bronx is not easy. If you live in the South Bronx, getting to the North Bronx is not the easiest, even though we have buses, subways, and some of our patients have what we call assessor ride, which is a transportation system for people who are older, who are unable to get around on their own. So, there's all these various things that come into play. It's not just one layer. You have to look at all of the layers, and that's how we can close this disparity gap.
Mhm.